Welcome to another video in the EduMed series on the ITU ward round, and today we'll be focusing on assessing the breathing system. We'll be going through what questions to ask yourself about the ventilator, how to deal with the patient who's hypoxic and how to deal with the patient who's hypercapnic, and finally how to wean someone off mechanical support ventilation. We'll go into this a little bit of detail, just touching on each of these, but basically each one of these topics will be a video in and of itself where we'll go in a lot more detail about it. I'd also recommend you watch the series of videos on the basics of ventilation before watching this, because it'll make a little bit more sense about exactly what's being suggested and why we do certain things. Assessing the patient's respiratory system is vital. A lot of the patients who come into intensive care end up with some sort of respiratory complication. Either they've started off with a pneumonia, or if they've been intubated for more than a couple of days, almost all of them start to develop signs and symptoms of a ventilator-associated pneumonia. So when you're assessing the respiratory system, the first thing to do is to look at the patient, then look at the ventilator, and then finally look at the monitor. The slight proviso to this is, if you remember the airway talk, we talked about having a look at the end-tidal CO2. I think that's really important to always have a look at whenever you approach a patient's bed space, because the number one thing you want to know is the tube that is in, be that an endotracheal tube or a tracheostomy, that it's sitting in the right place, i.e. in the trachea, and therefore providing a conduit for oxygenation and CO2 removal. So when you're examining the patient, it's just like in medical school. You listen to the chest, you auscultate, you percuss, you palpate, and you essentially try to ascertain what's going on with the patient. The respiratory pattern in positive pressure ventilation is slightly different to that in negative pressure ventilation, i.e. spontaneous breathing. When a patient is purely on positive pressure ventilation, they're not having any respiratory effort for themselves. What you tend to ventilate is more the upper and middle lobes, and the lower lobes tend to get compressed by the abdominal contents as the stomach and the liver push up on the diaphragm and thus compress the lower lobes. So if you hear better air entry in the upper zones than in the lower zones, that could be normal if it is just because the patient is on positive pressure ventilation. You need to really carefully listen for bronchial breathing, for signs of consolidation, to look at the chest, make sure that it's moving symmetrically just so as you don't miss a pneumothorax or collapse of a lung or a lung base, and also to percuss very carefully to make sure you detect any evidence of dense consolidation or that of pleural effusions. And you'll see that in intensive care we get a lot of patients with quite leaky capillaries, either because the oncotic pressure intravascularly has dropped because their albumin levels have dropped, or because the patients have become very inflammatory and therefore all of the inflammatory exudates cause the leak of proteinaceous fluid out into the body cavities, such as in the pleura. So make sure that you detect consolidation, effusion, see if you can detect a lobar collapse, pneumothorax. Pleural thickening isn't so important in these patients unless they're developing a empyema. But often there are signs and symptoms elsewhere from examination that would indicate that this is the case. Your examination of the chest is really a screening tool, and then the next thing you have to do if you find any abnormality is get a chest x-ray. That'll give you a better idea of exactly what is going on. But always examine the patient's chest and listen to it every day. You will find things change on a day-to-day basis, and if you've already listened to the patient before, you have a good idea of what their baseline is, and so will be able to pick up changes quicker and therefore be able to treat any underlying conditions at an earlier stage. Always ask yourself, is there consolidation? Can you hear bronchial breathing when you auscultate? Is there reduced air entry in certain areas? Is there the feel of rattling secretions there? Can you hear a wheeze? Quite often, patients become wheezy and have some bronchial hyperreactivity, which responds really well to nebulizers. And so if you find that patient's ventilation becomes more difficult, their peak pressures go up, or their carbon dioxide levels start to increase, always think, has the patient got some degree of reversible airways disease? And so start those nebulizers early. Like I say, lots of patients can develop pleural effusions, and sometimes it's actually really helpful to drain those pleural effusions, especially if the patient's got significant oxygen requirements and it's causing pressure on the lungs, collapse of the lungs, and therefore an increase in ventilation perfusion mismatching. Finally, with every patient, you must consciously make a decision to rule out a pneumothorax. It can be very difficult in patients who are mechanically ventilated, and you don't always see a pneumothorax on a chest x-ray, because chest x-rays are best for detecting pneumothoraces if you sit the patient bolt upright, because air will rise up. If the patient's sitting in a semi-recumbent position, air will rise to the top of the chest, which is the front, which on a normal AP chest x-ray you aren't going to be able to detect. And so be very careful with your examination of the patient. Look at the pressures on the ventilator, if they're slowly going up and up and up. If you're seeing that the amount of gas that the ventilator is giving to the patient with each breath is different to the amount that the ventilator is seeing back, it might be that you're getting a leak of gas into the pleural cavity and therefore slowly developing pneumothorax. And those pneumothoraces, if you've got a persistent air leak and you've got positive pressure ventilation, can very rapidly turn into a tension pneumothorax. So always look out for it. Like I say, if in doubt, get a chest x-ray. It won't show everything, but it shows most things, and you'll be able to pick up a lot of pathology there. Things that people often miss on the examination of the chest is actually suctioning the airway. One of the things that you need to be able to get an idea of is how much secretion there is and how infected it looks. If you've got lots of purulent secretions and the patient's not on antibiotics, you need to think about sending some off for culture. You need to start thinking about, if they start to spike a temperature, have they developed a ventilator-associated pneumonia? If you can hear a rattle and the nurses say they're not suctioning anything up, then you need to think about giving them some sort of mucolytic. Maybe the secretions are too dry and thick and proteinaceous for them to be able to suction up, or they're sitting too peripherally. And so for those patients, using saline nebulizers, using mucolytics such as carbamazepine may well help to loosen up those secretions. And the key thing with improving the patient's oxygenation is trying to get rid of the secretions and inflammatory exudate that sits in the lungs. To get a lot more detail on that, go back and have a listen to my talks on the basics of ventilation, where we talk about how we can improve a patient's oxygenation and CO2 removal. The next thing that you need to ask yourself is the patient synchronous with the ventilator? Now, we'll go through ventilator dyssynchrony in a huge amount of detail in its own specific lecture. However, for this, what I want you to just remember is, if you're in doubt and the patient looks to be dysynchronous with the ventilator, give them some more sedation. If you sedate them, then you can reevaluate the patient. They're not breathing against the ventilator, and that's what dyssynchrony is. It's where the ventilator is trying to give a breath and the patient doesn't like it and tries to take a breath for itself, or stops or tries to terminate the breath because it's happening too quickly or too slowly compared to what the patient's neural drive is for respiration. I will reiterate this in every video when we're talking about ventilators, but please go back and watch my series on ventilators. You must always have these two graphs up when you're looking at a patient who's on a ventilator. The first is the CO2 trace, and the reason the CO2 trace is vital is because it will tell you whether the endotracheal tube is sitting in the trachea or whether it has fallen out. The second graph that you must always have up is the flow time graph. Now, just to go over briefly what this is, and there's a lot more detail in my videos on the basics of ventilation, especially the one on I to E ratios, on how to set a respiratory time. But essentially, this is flow along here and time along the x-axis. So with the breath, the pressure suddenly increases, so you get an increase in the flow into the patient. So this is the inspiration. So this is all inspired time, and this is flow going into the lungs. And then at this point, the ventilator says that it's going to expire. So it releases that pressure, and so you get flow coming out of the patient's lungs and into the ventilator, and that's why it becomes a negative flow, because it's coming into the ventilator now. And then as the pressures between the lung and the ventilator equalize, you get flow coming out. And if you look at the dotted line first of all, you can see that the expiration time is long enough for the flow to hit 0. And at 0, what you're saying is that the pressure inside the lung and outside the lung are equal. The amount of gas that you've put into the lung is the amount of gas that you've come out, because there's no more gas to come out. Can you see here in the solid line where the flow rate doesn't actually hit 0? And what's actually happening is you're getting some gas trapping, because the next breath has already started, not all of the gas has come out, and so therefore you're going to get some residual volume there. And then if you do it again, you can see that the amount of gas that's there has increased, so you're trapping more and more gas with each breath, and that can be really significant. The way in which you avoid that is by increasing your expiration time, and we go through that in a huge amount of detail in the video on the I to E ratio, so I'd really recommend watching that. When examining a patient and thinking about their breathing, you also got to think about the mode of ventilation. Most patients, when they come into intensive care, are on a mandatory mode of ventilation. They're paralysed or they're very sick and they just need the ventilator to take over their breathing. So you can either set a certain volume of gas that's going to come in. And so, for example, you say 480 mils and you're going to give that every time. And so the ventilator just gives 480 mils each time and doesn't care what the patient's doing. Or you've got pressure control, where instead of setting a volume, we set a certain pressure, say 20 centimetres of water. And so every breath, it provides 20 centimetres of water, and then it releases after a period of time. Doesn't matter what the patient's doing. You've got spontaneous modes of ventilation, where the patient's actually able to breathe. And so what the ventilator does is very clever. It's watching to see when the patient takes a breath in, and as soon as it takes a breath, it gives a bit of pressure just to support that breath, so that it allows the lungs to fill up adequately, especially if you've got thick, stiff lungs, if you've got inflammation or infection on board. Then for those patients, by giving a bit of additional pressure, you can help the patient breathe and so decrease the work of breathing that the patient has. When weaning patients off mechanical ventilation, the first thing is to go from a mandatory mode of ventilation onto a spontaneous mode of ventilation. That's a function of reducing the sedation and seeing what the patient's neural drive is. You want to also try and reduce the fractional inspired concentration of oxygen. Above 60% is very, very dangerous. It can cause an increase in oxidative stress on the lungs and therefore increase the risk of fibrosis. So you really want to try and get the patient down to a reasonable level of fractional inspired oxygen concentration. Usually below 50% is what we'd be happy with. And once you've got your FiO2 down to a reasonable amount, let's say 40%, then you want to start thinking about reducing down your CPAP as well. This is the positive end expiratory pressure, or the PEEP. All the while, you need to maintain a lung protective volume of gas. You don't want to over-distend these alveoli by filling the lungs up with too much volume, and therefore using a 6 to 8 mils per kilo as your general target with regards to the tidal volumes, and then adjusting the amount of support that you're giving with the ventilator to achieve those sorts of volumes. So again, for an 80 kilo patient, that would be about 480 mils for a tidal volume. Dyssynchrony is basically where the patient is fighting against the ventilator. And we'll go through this in a huge amount of detail in a separate video. However, the first thing to know is that the best way to look at dyssynchrony is just to stand at the end of the bed and look at the patient. And you will see all of these signs, and it's exactly the same signs as you see in a patient who's got respiratory distress. Say, for example, they've got a really bad pneumonia, they haven't been intubated yet. They'll be using the accessory muscles of respiration. They'll be intercostal recession as they're really trying to breathe, and they're tachycardic as they're adrenergic. They may become cyanotic because they're fighting against the ventilator and not getting adequate gas coming into the lungs and therefore oxygenating. You'll see some abdominal paradox as it's fighting against a closed valve of the ventilator, and they'll become sweaty with a nasal NES flaring. All of these things tend to indicate that the patient is fighting against the ventilator and should prompt you to either change your mode of ventilation, change the settings on the ventilator, or sedate the patient more, potentially even to the point of paralysing them to stop them from fighting against the ventilator. That all depends on the patient's condition, the amount of oxygen requirements, the lung conditions, and various other aspects. And for all of those things, it's worth calling a more senior doctor to come and have a look and make that decision based on various other aspects. Like I say, we'll go through dyssynchrony in a little bit more detail, but in addition to standing at the end of the bed and seeing whether a patient is dysynchronous, you can also look at some of the graphs that are on the ventilator, and this is really the reason why those graphs are there. The first thing that you can sometimes get is double triggering. When the lungs start to expand up, it can cause the patient to think, oh, I need to take a breath. So in addition to the ventilator giving a breath, suddenly the patient takes a breath as well. So you can get this sort of double loop. And so you can see here with the volume again, you're getting a double volume, and that's because the patient is trying to breathe. They either preempt, so here you can see the patient's trying to take a breath and then the ventilator gives the breath. And this might be because the time between breaths is too short. And so the ventilator is giving the breaths over too long a period of time, and so you can shorten the respiratory cycle by increasing the respiratory rate if you want to keep the patient continuously with positive pressure ventilation and not synchronizing it with their breathing. Or similarly, you can reduce the respiratory rate and see whether the patient will start to breathe for themselves. Sometimes that's not an adequate minute ventilation, and so the patient's CO2 might start to rise. Here, on the other side, you can see where the patient's trying to take breaths. And you can see there's a little flow here where the patient's trying to do something, but it's not enough. Now, it might be that the patient's auto-triggering. So if you've set the trigger for the ventilator to give a breath to help the patient take a breath in, but the trigger is really low, so it only needs a small amount of flow to cause the ventilator to give an additional bit of pressure, then you can start giving lots of additional breaths to patients when they're not actually needing them. Again, very complicated. We'll go through this in a huge amount of detail in its own dedicated talk on ventilated dyssynchrony. Suffice to say for this, just have a look at the end of the bed, make sure the patient doesn't look like they're straining, and from the ventilated curves, just make sure they look normal. And again, the more you do of intensive care, the more you'll see what normal is. Now, with every single patient who has ventilatory failure, these 4 points are vital. This was originally developed for managing patients with severe respiratory failure, where they have significant ventilatory dysfunction. They may be significantly hypoxic with bilateral pneumonias or interstitial infiltrative processes causing them to be on 100% oxygen, maybe even going on to ECMO. But these same standards fit for every patient on intensive care. The first thing is make sure you have dried the patient out. You do not want to have extraneous fluid either in the lung interstitium or in the pleural cavities, pleural effusions. So make sure that the patients don't get too positive from their fluid balance. Every patient on intensive care for the first few days is in a resuscitative phase, and therefore given lots of fluid, you need to make sure you take all of that fluid out because it will leak into third spaces. Also, remove the sputum. The only way a patient will get better is if you remove the sputum and the purulent secretions that are sitting in the lungs, because they block off the alveolar units and therefore reduce the total respiratory epithelium that can be used for gas exchange. Make sure you treat the appropriate underlying condition. Now, it's really common for patients to come in with one infection, say a Staph aureus pneumonia, and then to develop secondary infections, be they fungal infections or other bacterial infections such as Pseudomonas. They all have their own resistance profile, so if the patient isn't getting better, if the consolidation is getting worse, if their fractional oxygen-inspired concentrations are going up, think, have you treated them with the right antibiotic? Do you need to escalate their antibiotics, or do you need to think about other agents such as antifungals if the patients are immunosuppressed or being on the intensive care for long periods of time? The other part of ventilation is thinking about lung perfusion. We went through this in a little bit of detail in the talks on the basics of ventilation, but it is really important to know that you need to not only have the lungs full of gas that's got lots of oxygen, but you also need to supply those alveoli with blood that is deoxygenated to allow the oxygen to diffuse in and the CO2 to be removed. If you decrease your cardiac output, you're going to reduce the amount of blood getting to the lungs and therefore the amount of blood that can be oxygenated. Also, if you have blood going to parts of lung that are completely collapsed, there's no point because they're not going to take part in gas exchange and so increase what we call the shunt fraction, the amount of blood that just doesn't see any oxygen and comes back into the left side of the heart. So improving lung perfusion is really important, and we go through that in a bit of detail in the basics of ventilation videos. So I really recommend watching those. So in summary, it's really important to examine a patient just like you would on the ward, but you need to constantly be thinking about what can you improve with the respiratory system. With the endotracheal tube in the right place, am I clearing the secretions? If not, how do I get those secretions out? You need to look at the ventilator and think, can you get them to breathe for themselves? Are you able to wean the parameters down, get them to do more for themselves, and therefore strengthen up those intercostal and diaphragmatic muscles so that you can help bridge them off the ventilator? You need to think about ventilator dyssynchrony. It's a big topic in and of itself, and so I'd recommend just watching the video that I produce on that to get a better understanding. The final and most important thing in some ways is every day you need to think about how can you improve the lungs, how can you get fluid off the lungs, how can you clear the secretions, how can you treat the underlying infection, is there a new infection there that's making things worse again? Only by continuously thinking about this and managing this are you going to be able to treat these patients and get them off the ventilator in a timely manner.